much as possible to clear up a lot of the confusion that may exist and to give you all a platform to ask questions of a doctor who's working at the forefront here in Seattle, Washington, on this. So we do have a few housekeeping rules I'd like to go over with you. So you're going to join by phone or computer, but don't do both. Do one or the other so we won't get the sound waves that are coming back and forth. This meeting is being recorded, and we will make that recording available at the end. Rachel, if you would hit that again for me. Yeah, hit a button just to advance because there's a little animation in there. Nope, there we go. Haha. And so those videos will be posted to the event page on Facebook for this meeting, as well as to the ACTU's web site. So you will be muted upon entry, and we'll try to keep you all muted. But if you are going to speak, you may unmute yourself to ask a question. But please, if you're going to do that, we just ask you to minimize the background noise. And just so you're not confused, you can see here what it looks like. To be muted, you're going to have that red line through the microphone, and to be unmuted, that red line goes away. And you will just click there, and that is in the lower left-hand corner of your screen. You'll find that capability. Next slide, please. So we're encouraging you to ask questions and to use the chat box if at all possible, but you also may unmute yourself to ask a question. So usually with our CAB meetings that we have here in Seattle, I often used to call them Stop the Doctor, that if you heard the doctor say something that you didn't understand, stop the doctor. You have that power. So we're going to try to see if we can have a similar spirit here. So if there's a question while she's talking that you need clarity in the moment, please do feel free to stop and get her to clarify. But if it's a question that you want to discuss later on because it has further implications, please save those till the end of our meeting because we're going to have a lot of time to chat. Okay? So just to introduce myself officially, my name is Michael Louella. I go by lots of different pronouns, both him and her and they. I like to switch it up like that. And I am the outreach coordinator for the University of Washington's AIDS Clinical Trials Unit. And would you? Yes, thank you. And I've been working here 20 years. It's kind of amazing to think of that. And I work as their outreach coordinator. I also coordinate the community advisory board and put on meetings and events all throughout Seattle about HIV and research. There's someone else who's joining us, and I wanted to let you know that. We have a Fred Hutch writer with us, and his name is Sabin Russell, and he's going to be like a fly on the wall here, and he's not going to be really participating, but he is using this meeting to write up what he's learning from this meeting to be able to share it more widely. And so I asked him that if he's going to want to use anything that people say, to not use anyone's name. So anonymity is the way he's going to do it, but if you don't mind, if you want your name to be used in something, you can privately chat him and contact him through the chat here. He won't be getting back to you through the chat, but he'll be able to if you just contact him and leave him with an email or one of your ways of contact that you may have. He'll get back to you that way. And lastly, I would love to introduce to you our guest speaker, Dr. Rachel Bender Ignacio, who is now the Associate Director of our research clinic. So without further ado, Rachel, I'm turning it over to you.
Thank you so much, Michael. So this is our COVID-19 updates and question and answer session. As Michael mentioned, I have Michael actually collated, and we together put several slides with questions that were written to us ahead of time. So we'll take those at the end, as well as any other questions that come up or that anybody would like to ask by chat or voice afterwards. So this is our roadmap for today. And with that, we'll start with a moment of reflection, and I'll turn it back to Michael.
Yes. This has been a challenging time, I'm sure most of you know. And when there's one death in a community, I think it diminishes the entire community. And I've learned of a death in our community here in Seattle. And I just wanted to take a moment to sort of reflect on those that we may have already lost this time around and those that we may lose. It's kind of humbling. to think 3 weeks ago you may have been talking to someone and now they're gone. So if we could just have a little moment of silence, I'd like to remember Charles. Thank you very much. All right, and back to you, Rachel.
Yeah. So after that somber note, I'd like to start right in and make sure that we're all leveled with the same terminology. We'll be talking about COVID-19, which is the illness or the disease, which is caused by the virus, which is now called SARS-CoV-2 or SARS coronavirus 2 because of its similarity to the original SARS virus. Just in remembering that there are lots of different names that have been given to this virus and to this illness in the 3 months that it has existed or been known to occur. It's very important, as many people in this community know and well understand deep in their hearts, that we are avoiding terms related to the origin for epidemics because of the inherent racism or other stigma and flaws associated with doing that. I know this is something that's near and dear to the community of people living with HIV because of similar issues related specifically to HIV. So I just wanted to call that out because many people right now in the United States are using other words that are not the preferred scientific terms for this illness or virus. So just as a really brief background, I'm sure that many of you have been inundated with the news and are reading almost as much or maybe more than I am. And so I'll go very briefly through what we know about the virus. SARS-CoV-2 is one of the coronaviruses. Many coronaviruses are circulating in the world, some found in humans, some the source of common colds. But the three that have really kind of risen to the top because of their severity of illness are SARS, which was circulating between 2003 and 2004, and extinguished both naturally and through public health measures, and MERS, which began in the Middle East and also was found throughout several countries in East Asia. And both of these were highly morbid and mortal infections. This is a zoonotic infection, which means it came from animals. And so this is similar to many of the other viruses that we know that cross into the human species via other mammalian hosts. In this case, this came from bats and transmitted. This is sort of like a cat for a civet here from SARS. We think that there are several intermediate hosts in SARS-CoV-2, but we don't know if they are important in the transmission to humans or important in the evolution to humans, or whether that they simply transmitted from the bat population. So a brief timeline. In December of this past year was the first known cases of a cluster of pneumonia that seemed to be unlike anything seen before except for SARS previously more than a decade ago in Wuhan, China. China informed the WHO of this new concerning case cluster, and the source, the Hunan seafood market, was closed shortly thereafter. Very shortly thereafter, the Chinese CDC actually identified and sequenced what they were calling the 2019 novel coronavirus, and testing became available for this virus. So this is all in very short order, less than a month. On January 20th, our first case was imported into Washington in a gentleman who had traveled to China and come back to Snohomish County. And this is just a little bit of a look at the rapidity with which this illness took off within China itself. And in very short order, we have some international action that's taken to try to slow the spread of this virus, specifically targeted at China. Continuing on, the United States reported their first death from this illness on February 29th. The first death had actually occurred on February 22nd and was diagnosed posthumously. Our state declared a state of emergency, and the United States increased travel warnings against other countries. And in the last 3 weeks, this has only been 3 weeks, we've seen the pandemic reach Italy and overwhelm its healthcare system. and shortly thereafter, the WHO declared a pandemic after infections noted in almost every country. And the United States declared a national emergency just last week. It's been a little bit over a week at this point. So I have borrowed a couple of slides that were presented at CROI from the Chinese CDC that just explain a little bit about this illness and its natural history. So we believe that most infections are mild. This is well known to us by now. About 15% are severe and require hospitalization, and 5% it result in critical illness, meaning requiring ventilatory support or high flow oxygen. We think that the average exposure to symptom onset is about 5 to 6 days, and the total illness course may be up to 2 weeks in people with a mild cold or flu-like illness, but in severe cases may take a very long time. And we also know that there's a significant amount of time that occurs between symptom onset until a person who may ultimately die will die due to lung complications generally. We do know now that there is truly asymptomatic infection, but we don't really understand how common it is because we're not testing as much people who are asymptomatic. But we think that it's truly rare that people have completely asymptomatic infection at this point in time, because most people who have asymptomatic infection at time of molecular diagnosis will end up having some sort of symptoms in the next few days. Again, familiar slides by now, but this is data from China showing that the majority of disease presents in people aged 20 to 80, represented in both female and male. And demographics, again, we see that the age distribution of cases is predominantly in those between 30 and 80. The median age is 50, and risk factors epidemiologically are healthcare providers during the initial outbreak and still in the United States. We see also that several comorbid conditions that have raised quite a bit of concern were present in people with severe disease, especially the foremost of which is hypertension. The prevalence of smoking in severe cases was quite high, diabetes, coronary artery disease, and underlying lung conditions. This is just a graphic representation of what was shown on a previous slide, showing that the vast majority of people have very mild disease without any pneumonia, or possibly with an abnormal chest x-ray, but without any symptoms of lower respiratory tract disease. And then about 15% of people have severe disease, which would require hospitalization and some oxygen support. And 5% or less have respiratory failure, meaning requiring a ventilator or having multi-organ failure. Here in the Seattle area, as I mentioned, the first case came on January 30th in Snohomish that was directly related to travel. We identified several cases posthumously in the first week after the first death was reported on February 29th. At this point in time, we have at least 15 long-term care facilities or congregant living settings that have diagnosed cases within them. And I just heard a report that King County Jail has at least one case, but they are doing a great job of infection prevention there. As of yesterday, so these numbers are from yesterday, we had 1,996 diagnosed cases. That number is approximately 2,200 as of this morning, but again, remembering that the true number of cases is thought to far exceed the number of confirmed cases because of the way that we're testing. So now I'll talk a little bit about transmission. As we know now, this is predominantly through droplets, meaning respiratory droplets, just like this gentleman disgustingly sneezing into the air, and fomites, meaning inanimate objects that can become contaminated. As you can see in this little table, copper seems to have some antibacterial and antiviral properties and is being evaluated as to whether impregnating materials could be antibacterial or antiviral. But this virus lives for quite a long period of time, especially on other metals such as steel, plastics, and then for a lesser amount of time on cardboard. And so that kind of comes into what we'll discuss in terms of which objects or which locations might be safe or less safe. There has been a lot of discussion about this recently, but we do not believe that this virus is spread by airborne mechanism. Airborne means microscopic particles that hang in the air and are not these large respiratory droplets that are shown in this picture. We can generate airborne particles or aerosols through interventions like nebulizers, intubating somebody, meaning putting them on a ventilator, or through high flow oxygen, which is why we're requesting that our healthcare providers that are giving care in intensive care units or doing procedures are wearing respirators and not just a plain surgical mask. But we do not believe that airborne spread is what is causing transmission in the community, again, outside of these few situations that have interventions. I think this has caused a lot of confusion, and I'm happy to talk about that more a little bit later. We do know that people can shed virus, and we predominantly think that virus is shed through the nose and mouth for about 20 days and may shed for longer in those that have very severe disease. There has been virus detected in stool, and at this point we haven't found any fecal oral transmission, meaning through contaminated food or through water contaminated with human feces. We know that we're just picking up virus, and we think that the virus is likely not viable that's being shed through stool. So there's much less concern about that route.
Rachel, we had someone ask, what was viral shedding? You were using that term and they didn't understand that.
Good question. So viral shedding means that, so the way that we're testing for this virus is via PCR. So we're looking at the genetic material or the RNA of this virus. It's the same way that we look and monitor HIV viral load. And so shedding means that we can detect virus coming out of somebody, in this case, via swabbing in the nose or the mouth. So we mainly think that, unlike some other viruses that can be shed through semen or through stool or urine or directly through the skin, that this is really coming out of the mucous membranes of the head, the nose, and the mouth, and that we can detect virus being let off from those areas. So asymptomatic carriers and asymptomatic infection is exactly what I was just explaining a little bit, meaning somebody who is not sick at all, but it is shedding virus. And we do think that that potentially up to 40% of the spread of this infection is through people who are having no symptoms, or maybe just don't understand that they're having any symptoms because the symptoms may be very subtle and may not be something that seems out of the ordinary for them, a tiny bit of stuffy nose, or maybe just a little bit of sore throat, a little bit of congestion. But that those people can actually still carry the virus in their nose and mouth. Again, we think the vast majority of people in this scenario will go on to develop symptoms in the next few days. And the studies that we've seen from China really show that people have the virus present in their nose and mouth for approximately 2 days before developing symptoms. So it's much less likely that people are never develop symptoms, but they may be infectious via shedding virus for the few days before they develop symptoms. We also think that this is one of the primary reasons that children can transmit the virus. They're much less likely to show symptoms, and they don't get as ill. But of course, children touch their mouth and their nose and touch everything else all of the time. And so we think that children are not only more likely to be asymptomatic, but we also know that they do a very poor job of keeping their snot to themselves. So for regarding transmission, what can we do to prevent infection? So this is where social distancing comes in. I know everyone has heard this again and again. The recommendation for staying 6 feet back comes from that knowledge that this comes in respiratory droplets, meaning that if you were to cough or sneeze, the average range that your respiratory droplets or your saliva is sort of projecting itself out of your mouth is about 4 feet. So staying 6 feet back gets you out of the range of that. Again, we don't think this virus is just hanging around in the air, which is why staying out of somebody's sneeze zone is really important. We're also requesting that people stay home if ill, and if, for example, someone has symptoms, whether or not you get a test for coronavirus, it's important to stay home at least 7 days after the positive test, or for at least 72 hours or 3 days until all symptoms go away. And that's just because one may continue to shed virus out of their nose and mouth, and be able to transfer that to other people, even if one is no longer sneezing or coughing. Hand washing, hand washing, hand washing. Very important here. We all know that the stores have been bought out of alcohol-based sanitizers. Hand washing with soap and water is actually better in all cases. And so if that is available to you, soap and water is still perfect. And again, we are requesting that people only use face masks if they are ill or in in close proximity to somebody who is ill. And masking is not considered to be necessary nor appropriate for people who are not ill, who are out and about in the community. All right, so King County has issued no such guidelines, but these are from New York, and I love them. Mm-hmm. They talk a little bit about how to have sex safely during the time of coronavirus. I won't read them in depth because they're quite long, but taking your word from the New York City Department of Health, you are your own safest sex partner, which I love to say. And the next safest sex partner besides yourself is somebody that you live with. And we should really think about, again, it's very difficult to have sex with somebody and be more than 6 feet away from them unless it's virtual sex. So just remember that these are some really great safety tips from the New York City Department of Health. So we're talking a lot about social distancing and changing our behaviors to protect everybody in the community. The Institute for Disease Modeling here in Seattle did some really interesting looks at what it would be like if no one changed their behavior, meaning that we didn't stay inside and we didn't reduce our social contact, versus if we changed our social contact by 50%, 25%, or 75%. So this was done several days ago and published in the Seattle Times, where today in King County, we have still less than 2,000 cases on the 24th of March. So I think, we're somewhere probably in this range right in here. So it seems already as though we have bent this curve and that we're doing a great job. So keep up the good work, everybody.
Nice.
This is just another really reinforcing graph. This was published in the New York Times yesterday. It's not surprising that New York is shooting up. This is a little bit difficult, I think, for a lot of people to interpret who aren't used to looking at log scales, because we don't usually talk about death rates in a log scale, but it's essentially just a way to make these become lines instead of kind of crazy parabolic curves. But what these gray lines behind is the doubling time for the rate of deaths. So we can see here that Washington initially had a very steep number of deaths. And that's predominantly because the way that that this infection was discovered in Washington was through infection in an elder care facility, in which more than half, I think 80% of that population was infected with the virus. And we had 30 deaths right up front at the beginning of this illness directly related to that care facility. And then as it moved into the general population, and now that we've been performing social distancing, you can see that Washington is beginning to flatten their trajectory, and we're doing a fantastic job. That is not what is happening in New York City. And I sincerely worry for many of the other states around the country that haven't been taking as clear measures as we have here under the direction of our governor and our mayor and other public health professionals here. So now probably the part of the talk that everybody's been waiting for, COVID-19 and what does that mean for people living with HIV. So this, I think, was a tantalizing slide, and I apologize for the resolution. Michael sent me this copy that was blurry, and I went back into the original talk, and I tried to find a better version of it, and this is my blurry version also.
And I tried to replace your blurry version with a yet better version, and it's still blurry.
Still blurry.
It's the source that sucks.
Yeah, exactly. So so this was a presentation, again, by the Chinese CDC at CROI, and I think that one thing that maybe people have interpreted this slide as is that if you see over on the right-hand side where it says immunodeficiency diseases, there are very few people with any type of COVID illness and very few critical illnesses here. However, if you remember, thinking about it, the people with immunodeficiency make up a very small proportion of the total population of China or of any country. And this is a lumping together of all people with immunodeficiency, not specifically HIV. And so I think it's very difficult to interpret. I think what this means is that there are few people with immunodeficiency of any kind, and therefore they're a small representation of the total proportion of cases of people with COVID. I would not interpret this to mean that people with any type of immunodeficiency are not at risk for coronavirus, unfortunately. And I think what we know, and I'll talk a little bit more, is that people living with HIV, as compared to the general population, have higher rates of hypertension, diabetes, cardiovascular disease, and lung disease for many different reasons. And so I think we'll talk about the fact that it's maybe these comorbidities that play more into risk for COVID than this one does, although that's not exactly how I would interpret this graph. I would interpret this graph as we just don't have enough data in this set of bars to understand.
Can I jump in with a question?
Sure.
Absolutely.
Now, we have a lot of people out here that are HIV positive, that have their immune system is really good because of the medications. They're undetectable, but they have underlying conditions like diabetes. Maybe they've had cancer in the past. How is that going to affect them if they come in contact with this coronavirus? Is there more chance of them getting it more drastically because of their other conditions and being HIV positive, or is it going to still be affecting them the same way as it would if they were just HIV positive?
That's a great question. I think that is that's one of the biggest questions out there right now in terms of how does coronavirus affect people living with HIV. We don't really have any understanding of how different CD4 levels, or being suppressed or not being suppressed, how long somebody has been on ART, or their nadir, meaning their lowest CD4 count ever, or their current CD4 count, affect their risk. So none of that data has been investigated yet. I will say that that's something that we're working very hard on at the University of Washington through our data through the CNIX database, which is a collaboration of CFARs across the country. Here we are leading the charge and looking at our own data from the University of Washington to understand whether there are any HIV-specific factors that are associated with risk of coronavirus. But as you mentioned in your question, that many people living with HIV have several other comorbidities, and many of those are related to years of taking antiretroviral therapies and weight gain and metabolic syndrome associated with ART or with HIV itself. And so my supposition, again, this is sort of hypothesis, this is not data, is that these factors, these other underlying medical conditions, are probably more important than being positive for people who have an intact immune system. The one thing that I think may be different compared to people that have other types of immunodeficiencies versus people living with HIV is that we know that HIV, part of the HIV reservoir, meaning where HIV can be hiding, is in the lung macrophages, so the scavenger cells in the lungs that are looking to fight off infections. And those cells themselves are part of the HIV reservoir. We know that in people living with HIV, those cells are chronically active. Okay, I think I'm unmuted now. And that there are higher levels of inflammation in the lungs of many people living with HIV. And we know that that has resulted in decreased lung function by pulmonary function tests and higher levels of lung inflammation in some people with living with HIV, even in the setting of having a suppressed viral load. So I'm putting this out there as an area of uncertainty. We don't really understand how this may affect people living with HIV differently from people without HIV or people that have other immunosuppressing conditions like cancer or cancer treatment. And then lastly, another word of pause and just, again, sort of a public health message about this is that we believe that smoking is incredibly risky for people developing severe coronavirus disease. And that probably relates to vaping and inhalation of other substances as well, whether that's marijuana, methamphetamines, or anything else that's smoked or inhaled due to the heat causing damage to the lungs as well as the chemicals themselves. And so if anybody was thinking of quitting smoking, this is the perfect time to quit smoking as well.
Rachel, we might want to stop here for a moment because there's lots of questions that have been popping up all about different things that we've been talking about. I'm going to try to read some of them. The first question, this was actually asked to me privately, but someone brought up that they wanted to know, like, the fact that we had the autoimmune diseases down at the one end, but then we had all these other problems that people with HIV often have in other categories. Can we be seeing people in more than one category? In other words, when we're seeing the data collection, they could be people who had autoimmune disease, but also hypertension, right? We should be tracking that together, as well as if the comorbidity is something that's related to HIV or if it's something that exists independent of it.
Yeah, absolutely. I mean, I think what we know from China is that the data about HIV and HIV metrics is I would say pretty underreported or pretty unclear, not just related to coronavirus, but we know that there's a long history of how HIV is handled in China. And so I'm not entirely sure how data collection went specifically related to HIV as a comorbidity. But I do think that these comorbidities add up. And so in some of the later papers, when I say later, I mean published like last week instead of 3 weeks ago, in this just total whirl of data coming out, is that people who have more than one risk factor are definitely at higher risk. So if somebody has diabetes and is older in age, and also has lung conditions, that person is likely at higher risk than someone who has just diabetes alone. Okay. Again, we don't know whether HIV adds to that as a separate risk factor or whether it's really just the risk of diabetes and age in someone who also happens to be positive.
And so also people have been asking about what about people who might be living with HIV who are co-infected with something else like hepatitis C?
Absolutely. I think back in one of these in the slides, we have chronic liver disease. Again, I don't know if that reflects hepatitis infection or if that's only scarring of the liver or cirrhosis, but that might be encapsulated here. We do think that people who have co-infections may not have as agile of an immune system. And so certainly that may be a risk factor, but it hasn't been fully investigated yet.
Great. And there was one other question and I lost it. Oh, I'll have to find it again. Let's, why don't we move on and we'll let people bring those up.
Sure. So I wanted to put together, this is just a page of some of the headlines of different web pages with interim guidance that has been written very, very rapidly. You can see that actually all 3 of these pages are dated March 20th. So this top one is from aidsinfo.gov that provides interim guidance for people living with HIV and the care of people living with HIV during the time of COVID. And I'll get a little bit into the to the summary of what these 3 organizations are all saying. So HIVMA and IDSA, so we released a statement that talks similarly about the clinical care, but also about resources. One of the main things that I happen to be on the board of HIVMA, and one of the things that we have been very active in advocating for is making sure that Ryan White programs are not dropping funding or causing any problems with interruption, for example, in people who are not getting viral loads done right now because they're deferring their routine clinic visits. And we've also been working with various other different organizations, including pharmaceutical companies and insurers, to help relax some of the restrictions on 30-day refills to see if we can allow people to have 60 or 90-day refills. The CDC has also released a webpage that says what people with HIV should know. Again, in the next slide, I'll sort of summarize all of these concerns. So overall, these three organizations, AIDSinfo.gov or DHHS, HIVMA, and the CDC, essentially say the same thing, that people living with HIV should practice social distancing and hand hygiene, as we're recommending for everybody, really. One recommendation is that it's okay to hold off on getting an HIV viral load or routine lab tests if someone is currently suppressed and is adherent to their medications. So the idea for this is that we're really trying to avoid bringing people into the clinic just to say, hey, how's it going? Haven't seen you in 6 months. Everything okay? Yep, everything's okay. Let's draw your blood. Not only does this protect people living with HIV from excess healthcare exposure, it also frees up our clinics to be able to see people who have acute illness. And it also allows our virology lab that processes viral loads to save some of their reagents and their personnel to be running more COVID tests. So this is a recommendation that many people may hear from their doctor, whether living with HIV or not, which is if you're due for your pap smear, if you're just want to chat to your doctor, let's do that by telehealth. Pick up the phone, let's talk to each other, let's stay in contact, let's hear your healthcare concerns. But if we can do it not in the hospital or clinic, then that's even better. And if that means that there isn't a HIV viral load for a year, so be it. We've made sure that our pharmacy will still continue to dispense medications, and there aren't any concerns about non-adherence to clinical care based on not having those routine lab tests done. Again, we're recommending that people verify that they have at least 30 days of medications. I personally am rewriting all of my scripts for 90 days, and some insurance companies are allowing that, some aren't. Some are releasing 60 days, but not all 90. So again, feel free to ask your prescriber to receive up to 3 months of your medication. That includes ART and every other essential medication. Somebody asked a question, I believe, about controlled substances, and unfortunately that doesn't include controlled substances, but many people are making exceptions for having personal contact with people, including medication-assisted therapy providers are coming up with some really creative solutions to allow people to access Suboxone and other essential medications without an in-person visit. As I mentioned before, it's never been a better time to quit smoking or vaping. And then there are some really interesting and exciting clinical trials that are coming down the pike at UW specifically. So here we are for therapies and trials. So as you'll note, the top line includes approved therapies. Currently, the only approved therapy for COVID-19 is supportive care, meaning taking care of whatever needs arise in the patient, whether that's supplemental oxygen, providing a ventilator, IV fluids, repleting electrolytes, treating low blood pressure, or ECMO, which is extracorporeal membrane oxygenation, or sort of heart-lung bypass machines, which are being used in extreme cases for people who have very sick lungs. Therapies, none are approved yet. This is very important, especially because last Thursday, I believe, there was an announcement that the FDA was going to approve hydroxychloroquine for use, and then that was retracted within 15 minutes because that was a announcement from the White House that was not substantiated by the FDA. We are, however, having many ongoing trials both in China and here in the United States for chloroquine and hydroxychloroquine. This is an alkalinizing agent that gets into cells, and what it does is it disrupts the ability of organisms, including viruses, that need to be inside of the cell to replicate themselves to be able to do their job. So that's how it impairs malaria. It was first a malaria drug, still is a malaria drug, by alkalinizing the vacuoles and spaces inside of the cells, and it messes up the pH that the virus needs to be able to work. So we think that this is very promising in animal models, and again, there are many trials ongoing for this right now. Remdesivir is the one probably that has gotten the most press. It's a broad-spectrum antiviral agent. It's a nucleotide prodrug, and it has great preclinical data in mice and in monkeys for both MERS and SARS. It was originally developed for Ebola. It was given on a compassionate use license to the first person who had COVID in the United States up in Snohomish, and the report is that he did very well after receiving that. However, that's a single case, and we have clinical trials that are enrolling right now, again, both in China, Europe, and the United States with this drug. Several others that are important to mention, tocilizumab is a monoclonal antibody against interleukin-6, which is a pro-inflammatory molecule in our body. And we think that interleukin-6 is one of the primary reasons that people develop severe lung inflammation and ARDS, or very severe lung failure. So this is a monoclonal antibody with some promise in blocking that really terrible inflammatory reaction. Intravenous immunoglobulin, which means sort of pooled blood products from people who've had the infection and who've recovered in the attempt to provide passive antibodies to somebody. These are being tested right now in China. We can't test them here yet because we don't have enough people who've recovered and have been able to give us plasma to make that happen yet. I'll talk specifically about lopinavir-ritonavir because that one is specifically on everybody's mind. And then favipiravir, which is another antiviral agent, which is, I don't believe, currently being trialed here in the United States. So let's talk about lopinavir-ritonavir. So what happened with this drug? Lopinavir, as we know, is a protease inhibitor originally designed for HIV. It's boosted by ritonavir when given. We do not think that ritonavir on its own has a lot of activity against MERS or SARS or COVID, but similar to how it's used in antiretroviral therapy against HIV, it's mainly being used as a booster in this case. I apologize, my arrow moved on my slide, but there is some suggestion in this clinical trial that was done and published recently in the New England Journal, I should have cited down here, that people had less acute respiratory disease with the use of lopinavir-ritonavir when it was given for SARS. But there are many different reasons why that study is difficult to interpret, one of which is that it wasn't randomized, and people, in addition to receiving lopinavir-ritonavir or Kaletra, were also receiving ribavirin and high-dose steroids. But again, because it wasn't randomized, people were receiving different amounts of each of these drugs at the discretion of their doctors. And then just this week, the results of the lopinavir-ritonavir trial for COVID-19 were published. This was a study with 200 people who had severe COVID-19, meaning requiring intensive care in China, was published. People were randomized to receive either Kaletra at the standard doses given for HIV or to receive standard of care alone. It did not have a placebo, but this was in the hospital. And so we do not think that placebo really impacted the ability for this trial to be done well. The main outcome in this trial was clinical improvement, which is a little bit of a squishy term, but what it means is that they categorize people into sort of 7 different disease states. 1 meaning discharged from the hospital alive, well, with no limitations in their function. 7 being having passed away. 6 being still in the ICU, requiring a lot of significant interventions and so on. So essentially the outcome of this trial was having moved 1 step in either direction, or 1 step positively. So you can see from this graph here, this is the main outcome of cumulative improvement rate. So again, this includes people who at the end of the trial at 21 days might have gone from hospitalized needing oxygen just to hospitalized but not needing oxygen. And there's really no difference here. There's a tiny bit of difference that's not statistically significant. And then viral load via nasal and throat swabs was measured. And you can see also that people who receive lopinavir-ritonavir versus receiving nothing at all, that there's no difference in the amount of virus that was being detected in the nose and throats of patients receiving Kaletra.
Rachel, so we had Kate bring up a point about the Kaletra trials here, and she said she was worried about the interpretation that these trials had failed, that around a 25% improvement in an intervention with nearly statistical significant results. She says, with a larger trial, might we have seen an effect? When millions of people are at risk of severe disease and death, even relatively modest efficacy could have major impact.
Yeah, so I think that the 25% was in a modified intent to treat analysis. So that was a sub-study of that trial that showed that if they excluded people who passed away very early on after the trial was started, and maybe hadn't received enough medication before the endpoint was measured, they did see a 1-day reduction in time to improvement compared to people who did not take Kaletra. I still think that there are a lot of other limitations. What we know from studies that look at viral shedding in many diseases, whether it's HIV or herpes, for example, it's pretty easy to have virologic effects, meaning to change how much virus we see, and whether that translates to a clinical effect often doesn't have the same exact power. So, for example, we know that for herpes simplex virus, acyclovir or valacyclovir can reduce shedding of the virus by 80%, but it only reduces transmission and symptoms by 50%. So the fact that here we see, oh no, it's making the whole curtain go again. So the fact that we see no change here at all on the virus makes me, I would say, pretty pessimistic about this. That said, there are several trials that are ongoing. I don't think that it's right to say that we haven't given lopinavir ritonavir enough of a shot. I think that we should not cancel the other trials that are ongoing. But what we do know, for example, and some of the things that the author said about this trial is that there's this number called an EC50, which is the 50th percentile of the concentration of drug at which 50% of the virus is killed. So we know that for SARS and SARS-CoV-2, the amount of drug that you need to kill 50% of the virus is much, much higher, and especially compared to MERS. And then when they looked at drug levels in this trial, and we know that, and when we look at the drug levels that we can reach in blood, giving people Kaletra with or without critical illness or with or without COVID, that we really can't reach levels in the body as high as are needed to kill COVID-19 or SARS-CoV-2 in the lab. So I think several studies have shown you can use lopinavir to kill this virus in the lab, but we just don't think we can get high enough levels into people with the dosing that we use. And additionally, some of the lab studies actually showed that there was zero effect even directly on cells in the lab. There have been a lot of other questions, and people ask questions ahead of time also about whether other antiretroviral therapy is likely to have an effect besides lopinavir. I think what we believe is that because lopinavir is aimed at HIV protease, it's the reason why we think it works is because it's a less specific HIV medication than some of the newer HIV protease inhibitors like darunavir or atazanavir, for example. So drugs like nelfinavir, which we all know worked less well against HIV and had more off-target effects, are probably actually working on other viruses, not because they work for HIV, but because they have all these untoward effects, which are the exact reasons that we abandoned them mostly for HIV. And
Rachel, you said all those names, but you used the generic names. Do you happen to know the brand names? Because I know a lot of people don't know dolutegravir or those names.
Okay, so darunavir is Prezista.
Okay.
And nelfinavir is, I'm entirely blanking on it, which is terrible because I have a clinical trial with nelfinavir.
It's Viracept.
Viracept. Yay!
I was thinking Viracept in my head, and then I said, no, that's the wrong thing. Yes, so Viracept. So some of these drugs that we don't use anymore, part of the reason we don't use them is because of all of the god-awful side effects of these medications. We actually think that the reason why those medications may work on other viruses is that they jam up human cell signaling. So in the process of jamming up the human cell signaling via a variety of alphabet soup mechanisms, they impair the virus's ability to hijack those human human mechanisms to photocopy themselves. So specifically because nelfinavir is such a sort of dirty drug, lopinavir also is kind of a dirty drug, not quite as bad as nelfinavir. It's sort of those off-target effects on the human cells that cause metabolic issues, et cetera, that are probably where it's working. So we actually think that other protease inhibitors, some of the newer protease inhibitors, won't work at all because they avoid some of those effects. And we don't have any evidence that any of the other classes, like nucleoside reverse transcriptase inhibitors, like Truvada, or integrase inhibitors like Tivicay, or some of these other combination medications, we don't believe that they will have any effect at all. They're really working on genes that are specific to HIV that other viruses don't have, or through the different mechanisms in which HIV interacts with human cells that are specific to retroviruses, which coronavirus is not. So I think there were a lot of people who had initial optimism about lopinavir. Again, there's ongoing therapies. Most of these are combination trials with ribavirin, with interferons, et cetera. But based on even the lab data that led to these clinical trials, I'm personally not sold. So I do want to talk about what clinical trials are in progress here at the University of Washington, because I think these are much more promising, and I think really can have both positive effects on the local population here, and will help us understand how to treat this virus. So I mentioned remdesivir, which is a drug produced by Gilead. There's an ongoing trial, which is an adaptive trial, meaning that the study design of the trial might change as we get more information. So currently we're comparing remdesivir to placebo, that in that adaptive format. If something else is found to be more efficacious than placebo, it may get substituted in. That trial has been open since last week at the University of Washington, Harborview, UW, Northwest Hospital, so all of the UW hospitals. This is open. People living with HIV are included in the trial. People who are pregnant are not included in the trial, and people who have significant underlying kidney or liver dysfunction may not be included depending on their numbers at the time of enrollment. Again, this is for hospitalized patients who are requiring oxygen or more therapies. Opening soon and will be a post-exposure prophylaxis trial using hydroxychloroquine. Again, this is an oral medication that has been used in millions and millions of doses, if not billions of doses worldwide, and it's pretty safe to give without a lot of monitoring. We'd recommend some monitoring, unlike the people who've been self-medicating with this since some of these announcements came out. But the idea is that healthcare workers or patients who have a confirmed close contact of someone who is swab positive, including people living with HIV, can sign up for this trial and be given hydroxychloroquine for 14 days to see if taking that medication after exposure prevents infection. So this is a placebo-controlled trial. It's being done as an outpatient. People are being given swabs and medication to take home. And again, this is a trial that it's not enrolling yet at the University of Washington, but it will be soon. Was there a question?
No, sorry.
That's okay. Okay. And then maybe most exciting here is a study that will be run by the ACTG, so a study that hopefully we'll be directly involved in, will be a study of hydroxychloroquine plus azithromycin for people who have tested positive to COVID-19 and are outpatients. So again, this trial is not quite open yet. We hope to open it here in a matter of weeks. It's not entirely a first for the ACTG, but it is an unusual trial in that this study is not aimed specifically at people living with HIV. This is a study that anybody who is COVID positive and doesn't require admission to the hospital can participate in. But ACTG has been asked to participate in the study because we have existing infrastructure and a lot of experience. And we've been tuning down some of our HIV research in the last week or two in order to protect our patients and study participants. So again, this will be open, a randomized study that will be open to people who test positive but don't require hospitalization. And we're looking to see if this combination of medications can prevent people from having progressive illness. Many of you have also probably heard that the Kaiser Permanente Washington Health Research Institute, which is what KPWHRI stands for, is partnering with the NIH to do a first-in-humans study of a viral preventative vaccine. So this is a very promising RNA vaccine that will be given to healthy volunteers. And I believe they're actually completely enrolled at this point, from what I'm hearing. And unfortunately, this is a study from which people with any underlying medical conditions were not included, because the idea was to test the efficacy or the antibody responses that could be generated by this vaccine under the best circumstances. And so later will be tested in a much larger population if it passes the first trial in a way that will be much more inclusive of a broad population. And then lastly, I mentioned that the local UW-CFAR has efforts underway as we are collecting information on people who are positive acquiring COVID-19 to understand what predicts acquiring COVID-19, as well as the risk of developing severe illness requiring hospitalization or requiring ventilator. In people living with HIV, and whether those risk factors are sort of HIV-specific risk factors or whether they're risk factors really related more to other comorbidities. So stay tuned for that. So this is my last slide before we'll just open this up completely to questions. And this is reflections. So I open this up to you. So how can the ACTU and community have an impact on COVID-19? So, I think we all know that during times of crisis and specifically during infectious disease pandemics, the interconnectedness of communities is really, really important. And that while we're social distancing, we should remember that's physical distance and not social distance, and that communities, all of our communities, can be tremendously supportive and impactful on each other. We also know that our communities here will have a lot of needs, a lot of critical needs, including housing and food. I just received an email from Lifelong that says that they're stepping up efforts to deliver food to people who are isolating themselves or who need it, as well as finding creative ways to support critical medications like medication-assisted therapy or Suboxone. And we also know that this will likely potentially have a negative impact on healthcare for other conditions. So people who just need to see their doctor about their diabetes will likely have a harder time getting that taken care of during this time. We talked about research. We know that people in the ACTU community and people living with HIV have been highly active in scientific research, both for prevention, vaccines, and treatment for the last 30, 40 years, actually almost 40 years at this point. So lead on. You all are leaders in community participation and research on all sides. And lastly, in stigma. As many of you know, that the stigma about where coronavirus came from and who might be affected by it is real. And it has a lot of really scary echoes, I know, for a lot of people in this community about kind of the early phases of the HIV epidemic. And so the CDC has issued a specific statement on this. And I know that a lot of people listening today are leaders in the fight against medical stigma. So I have a page of resources for you all. And thanks to a few other physicians and scientists who gave me their slides to borrow. And here's question and answers.
All right. And just to remind everyone, so I would love to open it up for you all to have a chance to ask your questions directly to Rachel. And so you can do that by unmuting yourself when you're ready to talk. We might find that this is a little bit difficult and have to kind of rope it together, but I wanted to open it up to you all. There's been many questions that have been popped up in the chat that I have not been able to stop things, but now we have our time to dedicate to talking to those questions that are burning inside you. So feel free to start.
Hello.
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 Hi, this is Rob Toth calling. I have a question regarding individuals who are HIV positive, those who may also have had a heart attack, kidney disease, etc. I have read that they are more at risk for a more severe case of COVID if they contract it. Is that true?
That is absolutely true. And I think that, again, part of the unknown here is how being positive interacts with some of the other medical conditions that you mentioned that have been well described in the literature so far.
Okay, so individuals who do have those comorbidities, would it be a good prophylactic to either self-quarantine or increase social distance?
I think we all need to be self-quarantined right now, other than for basic necessities like groceries. I'm self-quarantined other than having to go to the hospital to take care of patients. And so, I think specifically for people who have high-risk medical conditions, it's very important to maintain social distance. And if that requires getting help from other people to accomplish basic necessities like groceries, then that's important. But I think right now, to slow the spread of this virus through our community, it's not just the people that have underlying medical conditions that should be keeping their social distance.
Rachel, we had a request to go back to the previous slide. I guess people wanted to jot down what you had. Maybe it's the one before that. I think it's probably the resources.
Yeah, and these slides will be available to everybody afterwards, right, Michael? You're posting on Facebook? Okay.
Yes, we will.
So feel free not to hand copy URLs.
Yes.
And there's the titles, as I mentioned, on the page for resources for people living with HIV, from AIDS Info, from the CDC, and from HIVMA as well.
Okay,
right, so questions, go ahead.
So just to be clear, I have two questions. Well, first one is very simple, probably you can answer the easiest. Just to be clear, cardboard, plastic, metal products, stuff like that, we have to wash hands thoroughly after touching because it can live on those products, or it can't live on those products?
It can. We think that it is longest lived on surfaces that are not porous. So, thinking that metal is the least porous, that somehow in the, things that are absorptive like cloth and cardboard, that it probably sucks some of the liquid out of wherever the fluid that the virus is living in, and probably causes it to dry up faster and die, or become non-viable, since viruses are never actually independently alive anyways. So the most high-risk things would be something like stainless steel. So this comes into the really high-touch public space areas like door handles, entering and exiting a bus, the railings on a bus or on the transit, doors in and out of stores that are not automatic open, elevator buttons, things like this. We think that it doesn't live very long on cardboard or on cloth. So, when you go grocery shopping and you're opening up your food products, it's probably not necessary to sanitize your box of cereal that you bring home. Those surfaces like that are unlikely to hold on to the virus for very long.
Okay, and my second question is, there's a lot of mixed information going around online about this virus, where it came from, how it mutated, all this crazy information. There was one thing that I did read online, was how apparently it was a virus that was mutated from a snake meat and rat meat being combined in that Chinese market of exotic meats and animals. Mm-hmm. Is that actually true, or is that just false information, or do you know anything about that?
I think it's unlikely to have come from the mixing of meats, meaning from already slaughtered animals. The more likely scenario is that it came from coming into contact with each other, meaning live animals. We don't know whether it mutated in the bats itself and became able to infect humans directly from bats and happened to just be brought to the market via the kind of wild animal sales that are happening in those markets. We do know that one of the predominant reasons why we have some of these, avian flu or some of these other flu infections and other respiratory infections that hit the human population in Southeast Asia is the combination of the incredible population density in that region of the world, and also the close proximity of animals and people, and the fact that so many of the animals in some of these animal markets are not domestic animals, that they are wild animals. So what that means is it's essentially taking nature and bringing it right into one of the most crowded spaces on the planet. So it's probably an unlikely from mixing of species directly, and more just, close proximity of wild things that generally have their space and no longer have their space.
Okay, thank you.
Rachel, Kirsty asked a question that I thought I would like to raise. What implications do you think that the COVID-19 pandemic will have for funding for HIV programmatic research in the near future?
That is a really tough question. I don't know. My guess is that overall the level of infectious disease funding will go up. Whenever there is an epidemic, it tends to be that funding for that goes up. I think that overall infectious diseases will probably likely to be more highly funded than they were before, but I don't know that whether or not any of the other infections will end up taking a hit in terms of research priorities. One thing that we do know is happening right now, and I think for everybody to be aware of, is that in both our prevention trials networks, our vaccine trials networks, and our therapeutics networks, both for HIV and for any other condition, including for diabetes, most of these clinical trials are being put on pause, except for people who are already enrolled in those trials, and that's specifically just not expose people who are otherwise well to healthcare during these times, and to not, to allow social distancing to happen and to not put a strain on our healthcare system right now. So I think there will be a significant ripple effect for studies about HIV, whether or not it's related to funding. Hopefully it will be temporary.
Any other questions?
Rachel, I was wondering if you could talk about if we have any data on immunity after being infected and how long that might last or not.
That's a fantastic question. We think, based on kind of data coming from the SARS epidemic and from early data about this virus, that people will develop antibody responses and will develop some immunity to this virus. What we don't know yet is how long it takes to develop that immunity. So how long after an infection is somebody protected? We think it takes several weeks at least to develop those antibodies. And we don't know how long they will last. So will they protect somebody for one season? Is it permanent? We just don't know yet. And one of the other things that we know is that this virus is mutating slowly, and right now, not consequentially for in terms of our antibody responses, we think, but there is the possibility that this virus will change over time. Many viruses change over time for the better from our standpoint, meaning, for example, SARS actually lost a lot of its bite as it mutated. It became a weaker virus, and we were able to control it with our immune systems better. But we just don't know what the future is for this virus, and whether, next year it will be exactly the same, and whether antibodies developed this year will protect next year. These are all really fierce areas of scientific research right now.
Hi, this is Rebecca Maxim. I'm just wondering about competition for the same host cell. Since we have so many respiratory infections right now, is it possible that someone could have influenza but would not get COVID-19 because they're vying for the same epithelial cell in the respiratory system?
You've hit on a really, really important area of ongoing research right now, and a little bit of an unknown. What we know from pulling the UW data right now is we have not yet seen somebody who has influenza and COVID-19 at the same time. There's a small bit of data available from Stanford where they sent over 500 samples for respiratory viruses from their emergency department. 49 of those people had COVID and none of them had influenza. So we don't really know what that means. Our data here at the UW is a little bit difficult to interpret, because oftentimes if somebody tested positive for influenza, we then didn't send a COVID test. So we're waiting a little bit for some what we think will be great data from the Seattle flu study to understand that. We do know that for other viruses that are not flu, we have seen a lot of co-infection. So we found samples that are from people who had a swab that was positive for COVID-19 and run-of-the-mill coronavirus or para-influenza or respiratory syncytial virus. So some of these other viruses that circle all the time and just cause kind of normal, boring colds, we're seeing those viruses on the same swab that also has COVID-19 or SARS-CoV.
Mm.
So stay tuned.
Rachel, Teresa wanted to know if we know if people living with HIV have tested positive for COVID-19 and how they are responding.
Mm-hmm.
Have you seen this?
Absolutely. So I know to date of 6 people in King County who are living with HIV and have tested positive for COVID-19. And unfortunately, 1 person has passed away. As far as I know, the other people are doing relatively well. I don't have in-depth clinical data on them. But again, this is 6 people, so not enough to really hang our hat on yet. But this is part of the data that we'll be collecting through our CFAR database to try to understand this more in real time.
Thank you.
Hi, Rachel. This is Kate again. People that are prone to pneumonia or getting colds that move into pneumonia on them, are they going to be more susceptible to catching the COVID-19 virus, or is that going to make a play in it at all?
We don't know if you will. Shouldn't say you. Somebody who has these conditions would be more likely to get the infection. But we do think that if somebody who has underlying lung conditions or susceptibility to pneumonia were to get COVID-19, they might be more likely to have severe disease rather than just a cold or just a flu.
So do we have other questions?
Hi, this is Lori. This is not an HIV specific question, but I heard of an anecdotal report where somebody was claiming he lost his sense of taste and smell after his infection. Do we know is he incorrectly attributing this to corona? Are there other case reports of this? How common is it if it does happen, and is it of limited duration if it does?
Yeah, this is certainly, I would say this falls into case series, meaning it's not just one person who has noticed this, it's been several people. This isn't something that was really reported in China, and it may just be that in the initial studies they weren't asking. It also may be is for anybody who's had a severe flu probably knows is that they may not be inclined to eat or drink so much when you're feeling really lousy with influenza, and so they may not have been able to tease apart, sort of lack of appetite with actual loss of taste. And so we do think that this may be due to infection of some of the cells in the nose and in the throat, and potentially, on the tongue where this is happening. We don't know exactly why this is true. And I believe that one of the people who had reported this had reported regaining taste and smell afterwards, but I don't think we know very much about this now. But it is certainly sort of a new symptom that's important to think about.
Thank you.
Any further questions?
Yes, I would like to.
I have a question about whether or not ACE inhibitors or ARBs are creating more of a problem with the COVID-19 infection rate and death rates, given the statistics of diabetes and hypertension.
Yeah, great question. I actually had meant to answer this straight out in my talk. We just don't know. So what we don't know is whether or not it's having hypertension that's the risk factor, or whether it's taking this medication that's the risk factor. There is a mechanism. I'm just going to flip here to some of the other questions that people have asked, because somebody asked this question specifically. Is it uncontrolled hypertension, or is it only uncontrolled hypertension, or is it the medications that are the risk? So we don't really know the answer to that. the ACE and ARB class of medications have talk to specific receptors in the body, and there's different types of these receptors. There's ACE1, ACE2, for example, and some of these receptors are found in the lungs. There was initially a lot of concern that taking one of these receptor blocker medications might actually make it more difficult to mount an appropriate response against this virus. But then there's also some thought from some studies in Europe, mostly preclinical studies, that having these receptors blocked may actually prevent having the severe inflammation and the severe lung disease that's happening in some people. So this is an active area of ongoing investigation right now. And I think our medical recommendations is that anybody who's taking one of these medications for hypertension should continue to take that medication and should not stop taking it, because we don't have enough of an understanding to know whether it's just the hypertension or whether this theoretical concern of the ACE inhibitor could actually be beneficial or be harmful. So we're recommending that people stay on their usual medications.
Rachel, Laura wanted to know if you had any recommendations for caregivers of children who have HIV / comorbidities in terms of prevention of transmission or caregiving, recommended preventative measures for children and the people who are taking care of them.
Yeah, great question. I think that the most important thing is social distancing, which is always harder for children. It's the best prevention we have right now while we don't have a treatment or a vaccine. And so if it's feasible to the caregivers of those people to be caregiving for those children at home rather than in a group setting like daycare, we know that, obviously daycare is not social distancing. It's like the opposite of social distancing. It's like everybody else's snot in your child's mouth all at the same time, says the mom of a child in pre-K. And so, if there's any possibility of having those kids be cared for at home and just those kids alone rather than with other children who could be potentially bringing the infection home to those children, that's the best advice that we can give right now.
Go ahead.
I have a question. This is Tricia. I was wondering if I had TB twice. I'm wondering the condition of my lungs and how strong I am to overcome COVID-19 and the correlation between a person who had TB previously more than once and their readiness or their how that would affect.
Sure. We know that TB causes scarring in the lungs. For every person with TB, that could be different. There are some people who walk away from having a TB infection with very minimal changes to their lungs, and there are some people for whom TB completely wreaks havoc on their lungs and changes their lungs forever. So, so it's hard to say for any individual. We do think that anybody who has any underlying lung damage is probably more at risk for this infection as they are for any kind of pneumonia or any kind of severe infection. So it's important to take extra precautions if you're somebody who thinks that you might have lung damage for any reason.
Rachel, is there any truth to the different blood types being more susceptible than others?
There's some, I think, early data out of China that there's one particular blood group that may be less susceptible, that may have some slight protection. And I think it's entirely a plausible finding. We know that people's blood group determines in some ways how their body responds to different infections, and it's not only your response to infections, but for example, risk for having autoimmune disorders and other things that are correlated with blood type. So I think it is entirely possible that that there are some blood types that are or one blood type that's protected, somewhat protected at least against COVID-19.
And Sarah wanted to know if you could explain the use of azithromycin as a possible treatment, since it's an antibiotic and not an antiviral.
Yeah, great question. So we overuse azithromycin for everything. So it gets a little bit confusing about what azithromycin actually does. But the main use for azithromycin is to work against intracellular organisms. It changes the way your cell is able to handle organisms that have gotten swallowed into that cell and are living inside the cell. So because of that, azithromycin actually has a broad range of activity against, not really TB, it doesn't do very well against TB, but against MAC, which is a relative of TB, another mycobacteria, against things like, various other kind of intracellular unusual bacteria, and chlamydia, which, chlamydia is sort of a bacteria. It's an unusual sort of small type of bacteria that lives inside of the cell, and also doesn't perform all of its own functions without kind of hijacking the parent cell. So we think that some of those mechanisms that azithromycin has are more related to, again, to sort of the way a cell can handle a pathogen that it has swallowed, rather than specifically it being a bacteria or a virus.
And another question, can you confirm or deny the recommendation not to use NSAIDs? I don't know how you guys say that acronym.
NSAIDs. Yeah, NSAIDs,
Okay.
non-steroidal anti-inflammatory medications.
If infected, as they may exacerbate rather than relieve disease severity?
Yeah, this is another area of hot debate. You may have all seen, it was a tweet. I guess it was probably also a more formal recommendation, but also on Twitter from the Minister of Health of France, who recommended against the use of these medications. But then I believe some lab data from Switzerland that said that maybe they're protective. We think that there is a lot of confounding in trying to make that assessment, meaning that there might be one thing causing the other and not directly the NSAIDs. So one can imagine if they were homesick with a flu-like illness and were having severe body aches and a fever and a headache, the first thing that they might reach for would be ibuprofen or Aleve or something in that family of medication, and that they might, especially when recommended to not go to the hospital, especially if they were otherwise young and healthy, which is the population in whom this signal was seen, that one might try to treat themselves at home for several days with these medications rather than going to the hospital because everybody has them on hand. So we really don't know whether the increased risk is due to taking these medications, or it's just that young people who are otherwise well and treating themselves at home, who ultimately did poorly, had reported taking these medications. Again, there's a scientific reason why we think it might make sense that they could be either risky or protective, again, based on particular molecules, receptors that are expressed in our lungs that have to do with inflammation in the lungs, the cyclooxygenases, and we just don't know yet. So I think for now, many people are recommending to not take these medications if one thinks that they have COVID. But I think it's too early to say. We do know that Tylenol is in a different class of medications from these, and we do not think that Tylenol increased risk. Mm-hmm. And then I just right before coming online with you all saw a publication. When I say recent, like today publication, that showed that in a study from China that people who had received high doses of steroids actually had less of a risk of having who had severe infection, did better if they received high-dose steroids. And this has been another area of controversy. So anti-inflammatories, steroidal anti-inflammatories, non-steroidal anti-inflammatories, I think it's really too early to know.
And we had another question, and it's really about the sort of state of things that we're in right now. They wanted to know about this staying at home and limiting people in stores to help to control the virus. Is this really going to work, or are we going to have to go to some sort of full lockdown quarantine?
I think that most public health officials and most public health experts would say that a full lockdown can have more social harm and more, unintended consequences on marginalized populations than benefit. And there is a lot of concern in doing that. We also know that places, like Singapore and South Korea were really able to skirt having a big epidemic there by increasing social isolation without having a sort of strict military quarantine type scenario. On the flip side, I think we here in Seattle are doing a great job of social distancing and trying to, to isolate in a voluntary way, but that's not been true throughout the rest of the country. And so, my concern is not, is this not working? Because I think, my slightly optimistic hope is that this data is showing that we may be starting to bend the curve here in Seattle, but that these recommendations have really been followed in a way completely different in different cities across the country, in different counties, in different states. And the recommendations from the federal government are also, inconsistent. And so, so I think the concern is not that what we're doing here in Seattle is not enough, but the question is what we're doing as overall a society enough and fast enough and, being done in a concerted enough way that it's actually counting.
And another question that came up, for those of us who are not clinicians or epidemiologists, and in this person's case, they're a social scientist, what can we do to best support the field of HIV during this period?
That's a great question. I mean, I think that the field of stigma is important right now. And I think a lot of the lessons learned from stigma and HIV can be translated to this field. I think that understanding social isolation and comorbid conditions, not necessarily medical comorbid conditions, but substance use, homelessness, and some of the things that create vulnerability in people, and trying to, not only study those things, but also make an impact on those things. How can we support people living homeless, people with unstable living, or people who are dependent on methadone or Suboxone for stability, who are otherwise instructed to not leave the house right now. So I think kind of looking at some of those issues and trying to tackle some of those, whether it's not, through research or actually doing things, could be really impactful.
And someone else brought up a good question. How should we interpret all these graphs and numbers of infections and deaths and all the et cetera that we have when the testing is so very limited? How should we take any of this data?
Yeah, so I'd say that the grain of salt should be large. The grain of salt can be a little bit smaller here in Seattle, where we have quite a bit more testing than the rest of the country. I mean, really combined pretty much, with the exception of New York City. I think the data to follow is sort of accounts for both the numerator and the denominator. So looking at deaths and hospitalizations, we know that even if we're not doing a lot of tests in people who have mild symptoms, we can't miss those diagnoses because those make themselves apparent to us. And we, at this point, have enough testing, at least in the state of Washington, that anybody who's admitted to the hospital with severe illness is able to get tested. So those are numbers to follow. It's important to know that those numbers do lag, right? So deaths and hospitalizations will trail people becoming infected by at least a week, if not 2 to 3 weeks. And that's also part of the reason why we may not see all of the benefits of social distancing right away, is because right now we're looking at infections that happened potentially 2 weeks ago.
There was another question that Robert had. Robert, I don't know if you can unmute yourself and ask the question.
Well, which question are you referring to? I had several.
Whichever ones you want.
Go for it.
You have the floor.
Okay. Well, I got a question. Those of us who do have comorbidities that don't have a large support system, sometimes I have to go out to pick up my prescription. Sometimes I have to go do my laundry. When doing those activities, do those little blue masks really do anything?
It's a good question. We are not recommending that people wear blue masks out in the community, or any color mask for that reason. Part of the reason for that is that it actually takes quite a bit of training. It sounds silly, but it takes quite a bit of training to use them correctly. Using them correctly means putting them on with clean hands, taking them off with clean hands, not eating or drinking or smoking while wearing them, not sliding it over your face and nose while taking it off, and then keeping your hands clean, which is probably more important than the mask, especially if you're keeping your distance from people. So we're not recommending that people wear a mask unless your doctor otherwise has recommended that you do that, for example, in transplant patients who are requested to wear a mask at all times in public.
Okay. So basically, they're not a good prophylactic, period.
I think, there's some data that if everybody in society was wearing them, then we wouldn't have transmission. And again, that's less to prevent the person from getting infected as it would be to prevent people who are sick or who don't know they're sick from coughing it on other people. So, this is one of the things that was done in Singapore is essentially everybody is wearing a mask. And so if everybody's wearing a mask, then people aren't getting sick from people who are coughing or sneezing. And so it's less about the person who's worried about getting sick being masked than the person who is sick being masked, if that makes sense. And then hand washing. So it all has to come together right now. And, one of our big concerns here in Washington State, but also across the country, is the idea that we just don't have enough masks for our healthcare workers right now. So, it's not that we're trying to say that people who are not healthcare workers don't deserve to wear a mask. It's more that in the absence of thinking that it's actually providing a lot of protection, we're asking that the masks be saved for the hospital.
Rachel, are we seeing an increase in hepatic issues with the combination of COVID and HIV?
Not enough data yet. I hopefully will be able to tell you soon.
Okay. Do we have other questions that people would like to ask?
Yeah. Hi. Yes, Rachel. Thank you. You were very thorough about the reason why Calitra was selected and possibly useful against COVID, and why nalfenavir might also be useful. Could you speak a little bit more about the possible or the proposed mechanism of action of hydroxychloroquine? And I realize this would be speculation, but if it is being considered for post-exposure prophylaxis, might it be valuable as a pre-exposure prophylaxis also?
Yeah, absolutely. And so pre-exposure prophylaxis is being considered. It's mainly being considered for healthcare workers or that's really the only scenario in which we could use it as pre-exposure prophylaxis rather than giving it to the entire population. I think if we knew that it was really effective in preventing infections, we might consider giving it to very high-risk people, for example, people with cancer or with very weakened immune systems. But we don't have that kind of data yet, so it's certainly not a recommendation. It hasn't stopped people who have found ways to get this medication from just taking it. I'm not entirely sure where they get it because it's prescription, I guess as anti-malarials. We think that this medication works because it changes the pH inside the vacuoles and some of these other intracellular compartments inside of cells. So when a cell gets infected with coronavirus or any of the other, organisms that get inside of our cells, they're kind of transported into the center of the cell via vacuoles, and then there's all of these little, intracellular containers that package the virus and move it around. And then when the virus replicates, they have to bring it back out to the surface to let it burst out of the cell and cause new infection. And so this medication changes the pH in such a way that it makes it a completely inhospitable environment. Essentially, it's like it's full of bleach inside that compartment. And so, we think that's why it works very well as an anti-malarial, malaria living inside the cell. And for other infections such as brucella, for example, that live inside the cell, hydroxychloroquine can also be used. So we think that's the mechanism.
Rachel, Laureen had a question for you. Laureen, are you there?
Let me turn on my light. It's getting dark in my room.
I know, it's getting dark in my place too.
Okay. Better. All right. Go for it.
Laureen? Well, I can ask for her if she can't get on. She might have a problem with she wants me to unmute her on her. Oh, let me see. Hold on. Let me try to get her. Laureen. There we go. Unmute. There, try. Laureen. Okay. It says you're not muted on our end. Unmute all. Try.
Hello.
There you go.
Can you hear me now?
Mm-hmm.
Can we unmute Laureen? Chris?
I'm working on it. She should be. Laura Marine.
Okay, she said go ahead and read for her. So her question was, are there any trials planned to investigate the inhibition of SARS-CoV-2 spikes from docking on our cells, specifically the ACE2 receptor located on the exterior of the cell?
Yeah, I believe that there are a lot of ongoing lab studies, so not in people, but looking at samples from people in which they're trying to block those receptors and see if that works. I don't know of trials where they're looking at a specific receptor blocker, other than I believe that there's a trial in Europe that is looking, and I don't know whether it's randomized or not, about people taking those medications like an ACE inhibitor and whether that is beneficial or not. And I believe that there is an actual in-human trial ongoing in Europe trying to answer that question. In terms of other receptor blockers, I think that falls into the category of monoclonal antibodies. And the way that we get monoclonal antibodies usually is that we look at the natural antibodies that people make after an infection and purify them, and then try to, synthesize the ones that seem to be particularly good at neutralizing virus or blocking virus from entering cells. And some of them may, be specifically related to that spike ACE interaction. And so, those are, I think in China, some of those studies are underway, and in the US, they're starting to get underway to figure out which specific antibodies out of the serum or plasma of somebody who's recovered from this infection can actually do that job that you're describing.
And doesn't Corey Casper have a study that's looking at some sort of immunotherapy? Do you know about that? It was just announced.
Yeah, I believe it has to do with spike protein, and I apologize that I don't know more specifics about that.
I'm trying to look it up right now, but I can't find it. Oh, here, I found the Seattle team gets funding to start human trials of the, I'll send it to you, Laureen, if you want to read more about this other thing that I have.
Yeah, but most vaccines are aimed at the spike protein because that is sort of the dominant feature on the surface of coronavirus. It's why it's called corona, or meaning crown-like, because it has these sticky things sticking out, which is the spike protein. And so it's thought to be that's the part of the virus that's most visible to the immune system. So it's the most obvious target by any vaccine or by any immunotherapy.
So Rob had some questions, but I'm trying to find his questions where they are in the chat. Rob, if you can unmute yourself, and if you want to ask a question, feel free.
Well, I've asked the questions that I can actually remember. Old age,
Okay, that's no problem.
Just to clarify that, again, individuals with comorbidity issues should take all prophylactic measures that they can.
I'm sorry, I didn't hear that last sentence very well.
All individuals, whether HIV positive or negative, who have comorbidity issues such as heart attack, diabetes, kidney disease, should take all prophylactic measures as they can, correct?
Yes. I mean, I think we all should be protecting ourselves as best as we can, but explicitly anybody who is older than 60 or who has any of those medical conditions that you just mentioned should be working extra hard to keep themselves safe.
Okay, thank you.
And Rob Cook, I know you had some questions. Did you want to ask any of your questions?
Let's say yes.
Go ahead.
Can you hear?
Yes, we can.
Oh, awesome. I'm not used to this. You talked about the Z-Pack. If you do have one and you find out that you're infected and you start it automatically, would it reduce the chances of getting the virus? That's one question.
If you found out that you had the virus already?
Yes.
Okay. I don't think we have enough data to say that, so I would not encourage it. One of the reasons to be cautious specifically is that Even a little Z-Pack can cause effects on the conduction of the heart system. It can prolong the repolarization of heart cells, it's something we measure called your QTC on an EKG. And people who have heart infection due to COVID, which is something I didn't talk about very much, but somebody can have myocarditis, which is sort of an inflammatory infection of the heart muscle cells themselves due to this virus, could actually be at risk of having further heart problems if they also took medications that changed their ability for their heart cells to repolarize. So I think, as with everything, prescription medications should be taken under the instruction of a doctor. And at this point in time, we haven't studied azithromycin on its own, let alone do we have data in really more than 6 people from that study from France that began kind of all of the excitement about this trial with azithromycin and hydroxychloroquine. And so we would not recommend taking it on its own.
Okay, thank you. If you had PCP years ago, but you're really healthy now, undetectable, but 62, what fears do I have? Like just walking around the neighborhood, get on the metro, going to get my groceries. Should I wear a mask, gloves?
Yeah. If there's a way to get groceries without getting on the metro, I would recommend that. I think that staying off public transportation is something that we should all be trying to do right now. I appreciate that that's the way that many people get around all the time. It's the way I commute. Usually I've been walking to work instead because I have to go to work. And I think that people who can't safely move about should see if they have other mechanisms, whether that's through friends or grocery delivery or any of these other support groups like Lifelong, about getting deliveries of groceries to your house, because I don't think it's a great idea to be out riding the bus.
Okay, well, they just started the program with the senior hour that you can go in and get your groceries. Is that really safe? Because I would think there might be just seniors who are not being around other people. I feel like they could be walking around with it.
Certainly anybody could be walking around with it, not specifically seniors. I think that when you're shopping, maintain your distance from other people. And I think the most important thing is, I don't think that gloves are particularly useful, again, because when people out in the community wear gloves, they don't do it in the way that we do in the hospital. I'll give a little anecdote. I was pumping gas the other day, and there was a woman in front of me who came out of the Quick Mart with her toilet paper and pumped her gas and took out her car keys out of her pocket, got into her car, and then I watched her drink a cup of coffee, all while wearing gloves.
Oh, wow.
So my head just exploded, right? Because now she's done her shopping and pumped the gas and all the things that she was worried about protecting herself from. And now it's on her car keys, it's in her pocket, it's in her car, and it's on her coffee cup, and it's coming home with her. So,
Exactly.
I think this is why it's very difficult to wear gloves sort of all of the time and do it correctly. Healthcare professionals wear gloves while in a patient room, and then we take them off without touching the outside of them in a careful way, and then we wash our hands directly afterwards. So I think, coronavirus won't get in through your skin of your hands. So I would say, instead of wearing the gloves, go grocery shopping. Bring your own bag if you want to, your own cloth bag. If it makes you more comfortable to bag your own groceries so that you're only touching them. And then keep your distance from other people shopping. Keep your distance from the people who work at the store, and then wash your hands immediately upon leaving the store. And again, when you get home. And that's the best we can do to protect ourselves. Unless, of course,
Right.
you have the ability to have somebody shop for you or deliver groceries to your house. Those are both excellent options right now.
Yeah. Well, one last question. I'm on Trimed. I've been on it for several years. Now, suppose if I do get infected and I know a lot of new trials going on or new medications they want to try that you mentioned earlier. Do you have to stop the Trimed, or do we have to stop our medications so we don't get an interaction with the other medications that would be serious to us.
Which medication are you speaking about specifically? About the lopinavir, ritonavir, the other HIV medication, or?
Yeah, I mean, yeah, the ones that they have now, that they want to start now with the new virus.
Yeah. Okay. So to be clear, we're not starting any different HIV medications, Kaletra or lopinavir, ritonavir, because we do not think, based on this very well done trial in China, that they provide benefit. The new medications that we might start is azithromycin, remdesivir, hydroxychloroquine, and others that may come out. Each doctor who is providing those medications, whether it's through a clinical trial or just routine clinical care, will evaluate each person's medicines on their med list and check and make sure that none of those medications have any interactions. We would never ask anybody to stop their HIV medications, to take any of these investigational drugs. HIV medications, we think, are the most important things that anybody can take pretty much ever. And actually, that's clear guidance from AIDS Info, is whatever happens, if somebody's admitted to the hospital, if they're in clinic, no matter what, do not stop their HIV medications. So the question would be, can these other investigational medications be given safely with HIV medications?
Yes.
Most of them can be, and we would definitely not recommend stopping those medications. Potentially changing, again, only for people who have severe illness and who are in the hospital, who'd be doing that under very monitored circumstances. But in general, somebody's HIV medication gets preference to anything else they'd be prescribed.
Okay, that's good. It's very good to know. Thank you so much.
Rachel, we have Kate who has one more question for you.
Sure.
Hi, Rachel.
Hi.
My question is, I live with my 82-year-old mother. I'm her caregiver.
Mm-hmm.
And I go to the store only when I need to go to the store. I do this 6 feet as much as possible that I can do with other people. I'll literally stop going down the aisle because people are getting too close, and I'll let them go before I continue on.
Mm-hmm.
When I come home, I don't necessarily wash my hands the minute I leave the store, but when I come in the house, I enter the house. The first thing I do is set my bags or whatever down and then go and wash my hands.
Mm-hmm.
Is that enough to trying to keep the virus away from me and not bring it into a household to infect her? Because being 82 years old, she's, from what I understand, in that class to where she's more susceptible to it.
Sure. I mean, it sounds like
she is staying in the house most of the time. If she does go out, it's just for like a car drive somewhere and back home.
Yeah, absolutely. So it sounds like you're doing everything you can to protect her. Again, just making sure that when you're out, probably as much or more important than staying at distance from people is also just making sure about those high touch surfaces, shopping carts, door buttons, the pull handle on a door if the door to the store doesn't open automatically, where people are bagging groceries, etc. So just being cognizant of those places to touch, and if you can bring hand sanitizer with you or wash your hands, as soon as you can, then that's really important. Especially, one of the important things would be to make sure that, the door handles to your house that you're opening and closing also stay clean, so that you can protect not only yourself when you're coming and going, but also your mom. And I do think it is important to go outside. The governor specifically said that people should go outside for their mental health. I think the reason, at least my interpretation of why he didn't say you should go out for your physical health, is I think he's probably trying to discourage people from playing soccer games or go out in a big group bike ride and go hit it hard, and do sports that are sort of violating the group rules. But please go out for a walk, go out for a run, go out for a solo bicycle ride. Go and do those things that keep you healthy, as long as you're keeping your distance from other people.
Yeah, sanitizers are real hard to find right now. Hand sanitizers, hand wipes, all that. So I've made my own out of alcohol in witch hazel, and then I did one out of alcohol and basic water, alcohol and water one. I did use the, I think it's the 90% one of rubbing alcohol.
Okay.
And I couldn't find a lot of it, so in one mixture I had to mix between 90 and 70%. But my understanding is, as long as the alcohol is 90% or higher, or 70% or higher.
Yep.
Yeah.
So that should be sufficient. And again, hand washing with soap and water vigorously for 20 seconds is your best bet.
Yeah, and scrubbing the hands together. Yes.
Yeah, scrubbing the hands together. That's the friction. It's it's actually breaking up the pieces of the virus. Bleach also works. Not that I'm suggesting that that people put their hands in bleach all the time, but if it comes to, for example, cleaning off the doors to your house or cleaning off other things that you're worried about, a bleach solution is perfect for that as well. And the CDC actually has a really great list of how to make your own sanitizers that are virucidal, meaning that are strong enough to kill the virus.
Okay.
So, yeah.
And I just go on CDC's website.
Yep. Check out the CDC's webpage. It explains how to mix them, how to make sure it's strong enough.
Okay.
I'd like to jump in here because we're coming on 8 o'clock, so we've gone over a whole hour, which is great because we got a chance to really get into these questions. So I have 2 questions left. The one is from Rob, and he wants to know, does the virus get on our clothes while outside? Should we immediately change our clothes when we get back home? Do we put them in plastic bags? Should we not wear our shoes inside after being outside? All those sorts of questions.
Yeah. Good question. I don't think it's important to change your clothes for people who haven't been, directly in close proximity to somebody who's ill. I mean, I think if you were standing next to somebody and they did one of those huge sneezes, like that slide that I had with that really disgusting amount of spray on you, then I think it might be a good idea to change your clothes. I think healthcare workers are certainly thinking about or actually changing their clothes. I have a lot of colleagues, and myself included, who are changing our clothes before we let our kids touch us, or our spouses or anything like that. And I think that's just a whole different scale of touch when you're in the hospital with really sick people. I think if you're outside and you're grocery shopping and you don't think that somebody has, just expelled, the contents of their lungs directly onto your clothing, then I don't think it's necessary to change clothes or plastic bag them. Regular soap and water, regular wash cycle should remove the virus as well. And again, it shouldn't live very long on clothes. But we think that the risk of contaminating clothes is probably not that high. Again, if you're keeping your 6 feet of space from people, that should protect you.
Great. And so here's our last question that we will deal with for today. So the question is really about whether we think we really can get a vaccine for the COVID-19, especially given the fact that we've been trying for 30 plus years to get an HIV vaccine and haven't had any success. What success rate do you think we'll have with COVID-19 and a vaccine?
Yeah, so it's a great question. I think, that's a whole hours-long lecture, if not longer, on why the HIV vaccine has been so long in coming to us and why it's still eluding us. Several things that we know about coronavirus is, one, we know about the spike protein. We know a lot about similar spike proteins from SARS and MERS. And there actually was a vaccine from Dr. Hotez's lab in Texas that was very close to being developed. And I think a lot of the reason why there hasn't been a vaccine in development for some of the other coronaviruses is, number one, the kind of there's been no money or industry support for a vaccine just for like regular old, cold coronaviruses. And SARS, after SARS was extinguished, kind of lost momentum on that. And I think that's the reason why Dr. Hotez's vaccine hadn't ended up going to fruition. He's been talking about that a lot recently and testifying to Congress about that. And then there is I think some MERS vaccine candidates in development as well. So I think we know that we're pretty close with several close relatives of this virus, and we have a much better handle on it. And we also think that it's a lot less trickery. I mean, we obviously know that, HIV is sort of the queen of viruses in terms of the immune trickery that it causes. And so there are 7 different layers as to why we haven't been able to create an HIV vaccine. But we think for other respiratory pathogens, we do have some good vaccines for that, and we're hopeful.
Cool. Well, I think we should probably end our conversation here for now. So if you want to jump ahead to the last few slides, just to remind everyone. So we will be posting this meeting as a recording, and I'll be doing that on our Facebook page and on our website. I will send out links to everybody. People have asked for that. I just wanted to remind you that those are places you can look for that. If you want to send me an email, that will definitely mean I can email the link to all of this stuff to you. So if you want to, please email me. And the last slide there, I just wanted to say on behalf of everyone at the ACTU here in the University of Washington, we thank you for tuning in. We hope this was of help for you, alleviating some of your concerns. And just remember that, we're the ones that have to keep each other safe. And so do a good job. And thank you, Rachel, for your wonderful, wonderful example today of helping us all understand what's going on with COVID and HIV.
And I'm going to steal something from Mayor Durkin and wish everybody live long and prosper, just like Mayor Durkin says. So
yeah.
We'll wish that all for everybody.
There you go. All right. Thank you, everyone. Have a good night. Stay safe.